by the Vision Care Association in collaboration with the Eastern Mediterranean Council of Optometry. It's my pleasure to welcome you to the ninth webinar in this series titled Basics and Techniques for Ophthalmic Ultrasound. My name is Hassan, and I'm honored to be your host for today. It's also my great privilege to introduce our esteemed speaker, Mr. Khalid Qadha, who is a distinguished expert in the field of ophthalmic ultrasound. Mr. Khalid brings extensive experience and credentials, including lead of ophthalmic technicians and ophthalmic photographers at Cleveland Clinic, Abu Dhabi, certified ophthalmic technologist from the Joint Commission on Allied Health Personnel and Ophthalmology, certified ophthalmic sonographer from Wills Eye Hospital, USA, certified by Karl Ossoinig, the founder of a standardized A-scan, 14 years of experience at King Khaled Eye Specialist Hospital as a certified ophthalmic at CCAD specializing in A and B scan, standardized A scan and ultrasound by microscopy, and last, a dedicated trainer of residents, ophthalmic technicians, and nurses. Before we begin, I would like to share a few housekeeping reminders. Please kindly keep your microphones and cameras switched off throughout the session. If you have any questions, please drop them in the chat box of the Q&A at the end, and this webinar will be available for replay on the VCA YouTube channel. With that, I now invite Mr. Khalid Qadha to begin this lecture. Mr. Khalid, the floor is yours.
Thank you very much, Mr. Hassan. Thank you for the introduction. My name, as Mr. Hassan said, my name is Khalid Al-Qadha. I'm honored to be part of this lecture today and to be giving this lecture for the Vision Care Association. And let's start this presentation. I know they've been waiting for it. Inshallah, it will be useful for everyone. So as a beginning, what is ultrasound? It's simple words. It's a cycle of sound pressure wave with a frequency greater than the upper limit of human hearing. And as you see in the diagram down, you can see what is the use of the ultrasound, but mainly we will focus on the medical use, which is usually between 2 megahertz up to 50 megahertz. So what is ultrasound? The production of ultrasound used to penetrate medium and measure the reflection of signature supply focus energy. This reflection signature can give details about sorry again, hold on. Yeah, the reflection signature can give details about the structure of the medium. As you see here, the probe seeing the wave of the sound going inside to the eye, and it's giving you one dimension as a spike, or it will be as two-dimensional as we see in the B-scan picture. We'll talk first about A-scan. So it's a one-dimensional acoustic display representing vertical spikes. So how can we get use from this spike? So usually once you put that probe on the eye, you will get a certain spike. But if you want to go here like in biometry, the first spike, it will be usually the cornea spike. And this is if it's a contact technique. And there is the immersion. This picture here is for the contact technique. So the first one, it will be the cornea. Then here it's the anterior segment, the anterior lens, and then the posterior lens in the second part. And according to the velocity of each organ in the eye, then we'll multiply it by the time. Then we'll get the length that we are getting at the end, as we see here at the end of the screen. What type of A-scan you're using? There is the biometry, as we said in the first picture. And then we can see also the vector scan, which is a combination between a B-scan and A-scan. And usually we use this sometime to distinguish the layers if there is like retinal detachment, BVD, or choroid. Plus also can be a good tool to recognize some kinds of the lesions like melanoma or nevus, hemangioma, osteoma. But the main A scan is the standardized A scan for the lesion. It's more useful. It give more signature about the the lesion, and also sometimes give us a clue if this lesion is like vascularization is high or no. We go into the B scan. It's a two-dimensional acoustic, and it's a combination of vertical and horizontal dimension that shown in the screen as a dot, with multiple of these horizontal and vertical dimensions. You'll get the image as you see here in 2D. We'll talk a little bit about some physics, like the frequency. Uh, we have this low frequency, which is lower than 7 megahertz. Usually that will be used for most of the body. But when you use it in the eye, as you see here, even the lid, you can see it. You can see the whole anterior segment, the lens, and then also you can see the posterior. But we are losing a lot of sound waves in the side. You cannot get it all in detail. While in the moderate frequency, between 10 to 15 megahertz, you can see more details of the optic nerve, the posterior lens, and in the vitreous. It's more focused at that area. For the high frequency, between 20 up to 50 megahertz, usually it's for the UBM, the ultrasound by microscopy. And from there, you can tell like the higher this frequency, lower depth and lower of penetration, but more resolution and more detailed you see of the organ. Uh, we'll talk about the gain. The gain usually is helping us in the vitreous more. Usually, as for me, I start the exam usually with the high gain. Try to see if there is any vitreous opacity, hemorrhage, um, any opacity in the vitreous. And when we lower the gain, then we go more detailed about the ocular wall, including the retina, choroid, and the sclera. As you see in the upper picture, you can see some a little bit of, I will say, moderate echoic or hyperechoic with a BVD, which is the end of the vitreous, because this is a detachment of the posterior vitreous. When you go with low gain, most of this opacity will go. When we want to start the exam for a patient, we need to instruct the patient what we are doing before we put the probe in the eye. Position the patient most of the time in the chair as a lying or an incline. Applying the anesthesia if you want to do it on the eye itself, or without if you will do it over the lid. Me personally, I love to do it over the lid. It's more comfortable for the patient and easier and faster, honestly, because usually some of the patient will be very stressed touching the eye, and also apply, the anesthesia drop usually it's gonna give them some burn. Um, Clean the probe. This is the most important thing before putting the probe on the eye of the patient. Cleaning the probe is number one. Once you start your machine in the morning, you need to clean it. Once you finish the patient, directly clean the probe, because usually when you use the gel, it will stay on it and will have some crust on because of this the gel we are using. Why are we using the gel? We are creating a media between the probe and the eye, allowing the wave of the sound to go through it and give you a better picture. It's better, as I said earlier, to start the exam with the high gain to visualize anything in the vitreous cavity. We will change the gain accordingly if we are. That's depending about what patients coming for us for what is it? He's want to see if there is vitreous hemorrhage, or we want to see if there is detachment. So depending about the pathology, we're gonna change the gains. Start screening on the major four quadrants, 12, 3, 6, and 9. No particular sequence, but for me, I like always to start In these sequence 12, 3, 6, and 9, just make it as a habit for me to start in this way. If I forgot to label any of the picture, I know what's my sequence, I know which one I started with. Centering the pathology that we found during the basic screening, and that to give the best picture and more detail of the pathology. Place the probe opposite the exam coordinate. As you see here, the probe is in an inferior part of the eye, but once you put it there, then you are visualizing the superior part. Whenever you put the probe, you are visualizing the other side. If you put it nasal, then you're going to see temporal, and vice versa. Always ask the patient to look toward the area you want to see. If you, as in the same here in the picture, you want to see the superior part, so we ask him to look up, and as we said earlier, we place the probe inferiorly. Ensure that the tip of the marker is at the upper side of the picture. Place the probe on the lid or in the conjunctiva to start the examination. And as you say, when you see the marker here, that is mean that this is the top of the screen. Sorry. Place the probe in the lid. Gently slide the probe over the lid to the through the conjunctiva or on the lid itself, as I said earlier, from the limbus area up to the fornix, and that's allowing us to screen from posterior up to the anterior part. I always love to start to look for landmarks, which is usually it's the optic nerve. We start from optic nerve, then we know that we are in the posterior part, then starting to slide the or rotate the probe for equator up to the anterior. As we have three type of exams with transverse cut, which is screening most of the eye and take more extension when you do it. Place the marker nasally or superiorly. If you want to examine superior or inferior, then the marker should be nasal. If you want to examine nasal or temporal, then the marker should be in the superior part. Centering the hours we are looking for, we also try to center the pathology when we found it. Indicate the area you are examining by B, as in posterior, equator with E, anterior with A. So as a simple example, you can see that when you start from the posterior from the optic nerve, and then start to slide the probe up to the anterior. For the longitudinal cut, also it's different a little bit from the transverse. We will not slide the probe or move it. We will try to get one cut, starting from the posterior, which is the optic nerve, up to the anterior part. And also it's the same. Once you want to see nasal side or superior, the probe will be always in the opposite side. Ensure that displaying the specific clock hour begin the exam. So when you have this is the cut we'll get, as in the picture here. Optic nerve down. This is the equator part, and this is the anterior part. We have the axial cut. So we'll position marker on the center of the cornea. Most of the time we'll put the marker toward the nasal side. Place the probe over the center of the cornea, as I said earlier. Show the optic nerve and the posterior lens in the image. As we see here, the optic nerve here, and the optic disc, and the posterior part. But it came to my attention earlier with some people I trained before from other institute. Usually they do one cut, the axial. Then they think then once you do this, that you saw the whole eye. This is wrong. It's one cut, you're giving only one area. and you need to start always with the transverse to locate where is the lesion we are looking, or the pathology we are looking for. So one cut or one image, it doesn't mean that there is nothing in the eye. You need to screen and scan all the eye. As I said, here the optic nerve, and there is the this is the posterior lens. This is a small video showing how it is the technique of the, or how it's the behavior of the probe. Can you hear the voice? As you see here, this is the way, like how you imaginary see the scan of the probe. When he moved it, it's moved, scanned up and down, or like will be either to laser or to the temporal side. Okay. We'll go now after this for the 3D thinking. But earlier you saw the how he is moving the probe and how he scan the eye. This video you can get it in from one site website called Ophthalmic Edge. You will get it soon after the next video. There's another video. You can go and see it multiple times. I will advise that because this is one of the videos that taught me a lot to understand the behavior of the probe and allow me to give myself more knowledge by watching that video. So let's say that we found the pathology, and um, this pathology, like let's say an RD, we need to know the extension of the RD. Is it from posterior to the anterior? From which clock to the like from nasal to temporal, from nasal to the superior? This, once we get the cuts by longitudinal cut and the transverse, we will know what is the extension of that RD. But for this, we need to know to achieve this, we need to know the anatomy of the eye, understand the structure and components of the eye, and also uh, the history. It's one of the main reasons that make you better in ultrasound. You need to know the history of the patient. Patient did a surgery, or patient have a trauma, patient have retina problem before, glaucoma. You need to know what you're looking for. Once you know, it's easier for you to see or like to indicate what's in front of you and locating and the extension of the pathology, as I said earlier, by using the transverse and the longitudinal cuts, and determine which hours this extension going for. As an example, this is an image of a total RD open. This is how we see it, and this is how it's look in in real life. I mean, like the real eye. This is a total open shape RD. As you see here, the optic nerve area up to the oris serrata. The same here with the loop. The same from the other side also. Now this is another video talking about the 3D thinking.
Mr. Khaled, just there's no audio for the video. If you can explain what's happening during the video.
Okay, thank you,
Okay,
Hassan.
you're
Thank you,
most
Hassan, to let
welcome.
me. Yeah. So let me back again from the beginning. So as you see here in this picture, it's look as I said earlier, like a retinal detachment and opened. But once we start the image, this is like how it's look inside the eye. Let's wait for the probe to start. So as you see, the probe is going through the retinal detachment, and you see like a circle, which is representing the retina, which is in with uh, open detachment. If you move it, like it's going more bigger. If you go back, you see it's going small up to go into the optic nerve. And it will show you exactly how it's go. And this is like if you collect this image in your head, you should see it as you see it in the right side of the image. Like you see here, if there is like a tumor, it will show with you as like one dome. But if you moved it and you try to bring this image in your head, you see it in the same as it is in the real life. Here with like a detachment with a tear. I'm sorry if this video have no voice. I don't know what's the problem, but if you see the here down the ophthalmicedge.org, you can see this video and listen to it also. Thank you very much.
Thank you
And
very much, Mr. Khaled Qadha, for this insightful and highly informative session on ophthalmic ultrasound. Your expertise and experience have truly enriched our understanding of this essential topic, and we appreciate the time and effort you dedicated to share your knowledge with us today. Before we conclude, is there anyone have a question related to the lecture? If yes, please drop it
no,
down.
Mr. Hassan, I just need, there is another lecture, fast one, will show some of
Okay,
the cases I worked. It will not take long.
okay, okay,
Okay.
okay.
And then we'll go again for the questions.
Yes, yes, sure.
Okay. I'm sorry for that. So I collected some cases that I worked on before, some special cases, and inshallah it will be very helpful for you guys. In the beginning, we see a normal image of a normal eye with no vitreous opacity, normal ocular wall. As you see, when I'm moving here the eye, we go to the optic nerve and going back, but it's nothing, alhamdulillah. This is how it's normal. So my advice for everyone, if you want to start to ultrasound, please start with normal eyes. You need to visualize the normal. Whenever you see as much as you can from doing a B scan on a normal eyes, any abnormality, you're gonna detect it. Maybe you don't know what is this abnormality, but you need to know the normal to go for the abnormal after that. This is a video about a vitreous hemorrhage. You can see here there is hyperechoic area, which is the reflectivity in the vitreous, uh, the white area here, and also you can see the BVD and subvitreal. There is some hemorrhage also. We'll repeat this video again. You can see with the movement, it's inserting to the optic nerve as they adhere actually to the optic nerve, and you can see that there is some movement from the blood. Another video about the vitreous hemorrhage, but this with posterior collection for blood. I like always to say it, call it as a posterior hyphema, because there is a segmentation of the blood, like you see in this area. How can you differentiate this? And you see it, maybe you think it's in retinal detachment. It's by the movement. If you look here, you see the blood, it's sliding down with the movement of the eye, and then will go back again to the other side. If it's moving like this, that definitely it's not a retina or not a choroid. That's just vitreous hemorrhage here, and this is a collection of blood in the back as a vitreous hyphema, posterior hyphema, sorry. This is an image of a TRD. You can see the BVD actually is even layered in the vitreous, pulling the retina, giving this shape. It's like a tent shape. It's and actually it's pulling in two areas. You can see this hyperechoic space in the vitreous, which is indicate here the vitreous opacity. This is a video about choroidal detachment. You can see this is we call it kissing, and why we saying this because it's from two sides, from the let's say nasal side and from the temporal side, and it's touching each other with a little bit of retinal detachment at the end here, and this is the optic nerve. You can see also here the muscle. Um, this is a case of endophthalmitis. That was the first day the patient came to us after a surgery. We could see some layering here, disorganized opacity, and you can see here also hypoechoic area behind. It's supposed to be the sclera. Usually sclera is very hyper-reflective. Here it's hypo, which is indicate this, as I said, because the history of the patient, I knew this is endophthalmitis. Sometimes some patients come with low or hyper reflective scleral area. Usually that will indicate, sometimes it will indicate scleritis. That's why you need to ask about the history of the patient. If the patient coming with severe pain and recent surgery, most of the time it will be endophthalmitis. This is day 2. You can see also the same, more opacity happened after they injected the antibiotic in the eye. This is day 3, and this is day 4. This is the last day, and after that, unfortunately, this patient went to inoculation because it started to be banned in the endophthalmitis. And I'm going back because you can see for here that I'm looking here at inferior part. The probe is up, and I'm looking to the inferior at 6 o'clock. I'm following up, doing all the quadrant, but always I have one picture I like to follow it up to see the different for each visit. So all of them at 6 o'clock in longitudinal cut. This is a patient who came to us. A patient was a post-stroke for 2 years, bedridden, and they did an ultrasound in outside facility from the area from my work, and then they figure out how there is a lesion in the eye. They thought suspected melanoma. Um, Alhamdulillah, wasn't a melanoma, thank God. It was a dropped lens in the posterior globe. Um, and it's also at cataractus and calcified. You can see here the shadowing behind it. And usually most of the lesion will not have this shadowing except some kind of lesion like retinoblastoma because it have a lot of calcification within the tumor itself. This is a video of a giant retinal tear. It was 180, sorry, 180 degree cut from superior part. And you can see, sorry, you can see here the retina is going up and then flipped down because of the giant tear or the tearing of the retina from anterior part. But it still is inserted into the optic nerve. Uh, this is a video about macular hole. This is a macular area here. You can see the optic disc. This is the macula, and you can see the opening in this side. And this is with high gain. And then I will do also low gain after that. You can see, appreciate the opening or the macular hole, as you see here. It's difficult to find the macular hole, but this one it was because the separation in the macula, and also it was a really big hole. Sorry, this is a kissing choroidal again. This is an image of from Optos. If you notice here, you can see the elevation that's sent to me by doctor telling me there is a possible lesion in the eye. I want to know what kind of lesion. After the B scan, This is one cut from on the left eye, so that was the temporal side, and you can see the muscle, the lateral rectus muscle. But usually it's supposed to be thicker in this area, but it's too thin here, like it's been compressed. And when I did the transverse in the same area, you can see there is something pushing the globe, and thankfully there was no tumor. This is the zygmatic bone, which is the bone in this side. It was this is how it's I mean the bone was or the structure of the bone itself. It was in this side, this way. So it's pushed the globe, and it caused, as you see, the image here caused this elevation in the anterior part of the temporal side. And this is a video showing how it's pushing. You can see, you can appreciate the push of the globe, and it's also pushing the muscle. So here, this is this insertion of the muscle here. And thankfully it was in both eyes, but it's more in the left eye. So here, it just an image of superior ophthalmic vein, dilated superior ophthalmic vein. You can appreciate here the hypoechoic area. And after that, patient been sent to do a Doppler ultrasound for the whole orbit, and also they did for the carotid, and we discovered that the patient have what we call stenosis in the carotid because and because of that this superior ophthalmic been dilated. Thank you very much.
Thank you again, Mr. Khalid, for sharing your knowledge with us today. Really appreciate it. Before we conclude, I would like to ask you two questions. The first one, with advancement in imaging technology, how do you see ophthalmic ultrasound evolving in the next decade? And what emerging trends or techniques should practitioners start preparing for?
Um, the I'm looking forward to see 3D images for the eye for ophthalmic ultrasound. Till now, also I didn't get any information regarding if there is the AI solutions going with ultrasound to make things easier. Um, I'm looking also forward to see more advanced in the anterior segment, like in the UBM. Still, it's a very raw science. Not that much of people know about it, but I wish in the future we'll get in cooperating with the companies to see what we can do in it regarding
Okay.
advanced.
So the second question is, how can ophthalmic ultrasound be integrated more effective into patient-centered care, especially in diagnosing and managing complex cases with minimal patient discomfort?
As I said earlier, I like to do over the lid. And like when we do it in the eye, it's really make the patient very stressed. Um, when you do it over the lid, the patient is more cooperative with you about moving the eye and ask them to rotate the eye in which area. While when you do it in the globe itself, as I said, discomfort is very high, and sometimes you reach some patient really refuse even doing the exam. Um, it is already invasive technique or test. So I don't
Okay.
think more about it honestly than this way.
Okay, so there is one more question from Mr. Amara Zafar. My question is that, as you told us, if we place the probe inferior,
Mhm.
so we see the superior side. So while mentioning the image, what will write 6 o'clock or 12 o'clock?
No, 12 o'clock. You're not mentioning the probe area. You're mentioning what you're visualizing. So if you put the inferior, you are putting the probe at 6 o'clock, but you are seeing 12 o'clock.
Okay, thank you so much for your valuable insights. Now, I would like to extend my sincere gratitude to all our attendees, especially Mr. Basim Bouhabib, who is a big supporter for VCA, and for your active participation, Mr. Khalid Qadha. Your
Thank you.
engagement is what makes these webinars meaningful and successful. A quick reminder that the recording of this webinar will be available on the Vision Care Association YouTube channel. So feel free to revisit the session or share it with your colleagues who may have missed it. On behalf of the Vision Care Association and the Eastern Mediterranean Council of Optometry, thank you again for being part of this webinar. We look forward to welcoming you to our future sessions. Wishing you all a wonderful evening ahead. Thank you so much.
Thank you, Mr. Hassan, and I hope I've been useful for everyone and I gave good information.
Yes, sure.
Thank you.
Thank you so much. Thank you.
Welcome.